Hello, everyone. Welcome to RegenMedGlobal, the podcast, where we bring you the latest and greatest in the field of medicine and research. Today, we're here to talk about cancer and the latest therapeutic developments. To speak with us about this topic, we have one of the leaders within this field. He's the medical director of Beverly Hills Cancer Center and assistant clinical professor at UCLA School of Medicine. I'd like to introduce everyone to Dr. Eli Gabayan. Dr. Eli, it's a pleasure to have you here today. How are you doing?
Good, thank you, and it's a pleasure being here.
Thank you. Before we get started, I'd love to have you just share a little bit about your background.
Sure, of course. So I'm a medical oncologist and hematologist in practice for over 20 years, and I've seen a lot of new changes over my career. When I finished my fellowship in oncology, for example, colon cancer, advanced stage colon cancer had about a 9 months survival with treatment and 6 months with no treatment. And right after my fellowship, we had some new drugs that we started using. That survival went to 2 years and then 4 years. And these days we have 6 to 10 years even for some patients. So it's a whole new ball game. That's just one example. On top of that, we have immunotherapy that's been approved recently for many different types of cancers, including for melanoma, for lymphomas, Hodgkin's lymphomas mostly, and for lung cancer, as well as other cancers that have multiple mutations, we call it, or they have a high mutational burden. So the whole immunotherapy field has really been very exciting for all of us as oncologists and for our patients, of course, and that's the most important. And beyond that, we keep going further and further into different technologies, for example, using what we call antibody-drug conjugates. We have an antibody that's coupled to a chemotherapy together, and it kind of hones in or is targeted like a cruise missile that goes right where the all the tumors are, and it starts to attack him right at the site of the tumor. So that's also very exciting that we're using these days, and we're doing a lot of clinical trials for these types of treatments. And I would say one of the most exciting things that I've been doing personally lately is the bispecific antibody treatment that we have here as one of our clinical trials in our research program, where we use this new antibody technology with two arms that recruits the immune system to attack the cancer. So specifically, we have been doing it for multiple myeloma lately, and it's been really extremely exciting seeing these patients who have very little, options, or very few options, and sometimes no options for treatment. And they come to us, as a last resort almost, and we offer them this treatment. You have to watch them closely for the first few days or a week or so, and they have some little reaction here and there, but we help them through it. And after a week or two, we see miraculous results in the treatment. And it's really just their own immune system attacking the multiple myeloma cells. And that's been extremely satisfying and very exciting to be able to have this kind of option for patients who, about a year ago, or even 6 months ago, had no such option.
Wow, that's amazing, Dr. Eli. I want to definitely get into that a little bit more detail, but for many of us who this might be a new topic, can you just tell us a little bit, okay, what is cancer?
So cancer is just a few cells that who start dividing abnormally, and they just don't die, and they keep dividing and dividing because their system of growth has become abnormal due to some kind of a genetic change in their growth pattern. So they don't know that they need to die at a certain time. So they keep dividing and growing, and then after a couple of years, that little cellular cancer becomes a big tumor. So it takes a long time for the cancer to show itself, but it's basically an abnormality of the cell cycle, of the recycling of the cells. So all of our body cells are always turning over every few months or every few days in some parts of our body. But some of these cells that are supposed to be turning over, they don't. They keep living and living, and they grow and they start to grow in different areas, and sometimes they metastasize, and you have to figure out how to get at them because they are very smart in terms of how they can basically hide from the immune system, first of all, and also they learn to adapt to whatever treatment we give, we give our patients. So after a while of responding, then they stop responding. The cancer starts to grow again. So it's tough to figure out what is the mechanism that is making them hide from the immune system, as well as some cells that basically escape from the chemotherapy and start to grow again in the future, even with chemotherapy or radiation therapy. So lately we're figuring out that it's not really just one pathway that we need to attack. We need multiple pathways to attack cancers. Once we figure out how to do that best, then I think we'll have a really, a real success story in how we can treat cancer, either cure cancer or eventually make it into a chronic disease situation where our patients can live with the cancer for a long time. For example, with high blood pressure or diabetes, people live for a long time. We don't necessarily cure high blood pressure or diabetes, but we can help our patients live with it for a long time. And that's the goal in our situation. If you can cure, great, but if we cannot cure because it's so advanced, at least can we help our patients live with the disease for many years.
What types of cancer do you treat? Is there a particular specialty, or is it all forms or types of cancer? Can you tell us a little bit about that?
Sure. So we have a group of us at our cancer center, and most of us specialize in different areas. I personally see a lot of prostate cancer and colon cancer, but as I said earlier, I'm also doing some research in multiple myeloma, and I see other types of cancers that come, but we try to focus in different areas because there's just so much knowledge out there. It's hard to know everything about everything.
With the different types of cancer, is there more a standard way of treating them, or is there a different way of approaching each different types of cancer as to where it is and what type it is?
So each different cancer is different. Each different cancer type has its own pathology and molecular makeup. And in fact, each patient's cancer can be different from another patient's cancer. So one patient's, for example, breast cancer is not the same as another patient's breast cancer. So there are a lot of different molecular testing that we do these days, including in the blood and in the tumor itself, to figure out what is the makeup of that particular patient's tumor genetics, or the molecular biology of that particular patient's tumor or cancer. With that information, it will help us to really come up with a personalized and targeted treatment for each patient's situation. So it's not only that not all breast cancers are the same, but also every single patient is different than another patient. So it's we have a lot of more testing lately, more diagnostics at our disposal, and therefore, based on that, we can come up with more different treatment, regimens for each patient.
What type of technology is or treatment is the most kind of standardized or most common way of treating cancer today?
So I don't know how to answer that as far as most common way. I mean, basically, depending on the type of cancer and the patient's molecular makeup of the tumor, then we figure out, what is the most appropriate option for that patient. Sometimes it's chemotherapy, sometimes it's a combination of chemotherapy with immunotherapy, sometimes it's chemotherapy with radiation therapy, sometimes it's only radiation therapy, sometimes it's hormonal therapy. So, for example, many prostate cancers and breast cancers can be treated with just hormones alone. So that's nice and easy and very few side effects with great responses. So it really depends. We cannot say any standard for any type.
Can you tell us a little bit about maybe how you currently, let's say, I understand you personalize it, but of the personalization, what type of treatments do you often utilize?
So So we utilize, first of all, the diagnostic approaches that we have. What we have is the next generation sequencing testing on the tissue. So we send that test to really get a better idea of the makeup of that tumor. What are the mutations that may be involved in that tumor. And also we can send the blood for the same kind of testing. So very often patients have circulating tumor DNA in the blood. And we have this very powerful and sensitive test that can find those, basically, they can call it the needle in the haystack. They can find that tumor DNA in the blood, and then they can analyze it and see what is the makeup of the DNA of this particular patient's tumor. So we put all of that information together from the blood, from the tumor genetics, for next generation sequencing in both testing, and we come up with what we think makes the most sense for that particular patient. So yes, truly a very personalized treatment approach. So not everyone is doing that all the time these days, unfortunately. I think there's a learning curve for this. There's a lot of information that comes with it, and most doctors don't really know what to do with all the information.
Why is it not really utilized right now? Is it because of what you said, just people don't know how to use the information, or is it just this technology is not widely accessible? Can you tell us a little bit about that?
It might be a combination of both. The technology is accessible, but not all the time for every patient because of some of the insurance issues. And not all doctors are in tune in ordering the test all the time as well, as far as I can tell. So I think it's going to take some time for everybody to become comfortable with the new technology, and for the insurers to start approving it, and for the doctors to start ordering it. But even if you order and you get the results, then you have to know what to do with the results. So that's another area where you need more education and training, for the doctors to really be comfortable with the information and to be able to put it to use for their patients.
So let's say you have this information, right? I know you talked a little bit about it earlier, but if you can maybe just kind of refresh our memories. You have the information. You want to find a way to tackle the cancer. What are the different methods? Is it chemotherapy, immunotherapy? Are there any other types of treatment approaches that you guys take?
So sure, there's, as you said, chemotherapy, immunotherapy, or what we call targeted therapy. There's a lot of agents that are really targeted and focused to a certain tumor type. So for example, in breast cancer, I saw a patient recently who had very advanced cancer, and I thought for sure she needed chemotherapy. We did some special testing. We found out that her hormone receptors were very positive, and she wasn't really in an emergency situation to get chemotherapy. So we decided to give her only hormone therapy with a targeted agent at the same time. Only 2 pills, 2 types of pills. And after 2-3 weeks, she's much, much better. So just with a couple of pills, she is responding beautifully. Her pain is almost gone, and she's walking around, almost as a normal person. I saw her earlier today. So, to get to your question, it could be chemotherapy, it could be immunotherapy, or it could be only hormone therapy or targeted therapy, or a combination of any one of those.
Wow, that's interesting. Can you maybe share with us maybe like a story or two about, I know you just shared with us right now about breast cancer, but any other stories in terms of technology that you use right now for treatments and how you've been able to help some patients that came across cancer?
Definitely. So just very recently had a patient with multiple myeloma who got all kinds of treatments over the last probably 2 decades. Has been dealing with her disease and got the different chemotherapies, different, other agents, immunotherapies even, and was about to go for CAR T cell treatment, which is a very interesting, a scientific way of treating cancer these days. It's called CAR T cell, which is a way of getting a patient's immune cells and exposing them in the laboratory to see different antigens, and then re-infusing them back into the patient to go fight the cancer. That's a very involved process. It takes a lot of time. It takes a lot of science and technology in the laboratory, and it's not easy to tolerate for a lot of patients. You get a lot of side effects and allergic reactions, etc. And they have to be in the hospital for about 3 weeks or so. So it's a very involved treatment and difficult to administer. So she didn't qualify for that, unfortunately, and she came to us, as a last resort. We gave her the bispecific antibody treatment on a clinical trial. And the first week she was barely walking, and she couldn't walk to the bathroom. We had to help her to the bathroom. And we had to use a wheelchair to take her, in and outside of the room. After a week, she came back and she was feeling a little bit better. She was walking, she was feeling much better. Her pain was much, much improved. And her appetite was better. So it was almost like a miraculous turnaround in her clinical status. And then we did some blood tests. We see that this protein level that was at about a level of 550 had gone down to 1.6. It was like an unbelievable response that we were all very excited about. So we see these things happen. It's amazing, and it's very fulfilling for us. Obviously, for the patient, it's life-changing and life-saving, and that's what we live for. That's what us doctors, that's our challenge in life, and that's what we enjoy watching.
That's
And
amazing.
that we strive to bring more and more such treatments to our patients.
Is this, tell us about the treatments. I mean, now I know you talked about it a little bit earlier, but I'd like to touch on it a little bit more now. What are the clinical trials that you're involved in right now?
So we have multiple trials. We have a whole bunch of clinical trials open for different types of cancers, for breast cancer, for prostate cancer, for lung cancer, etc., and for, as I said, for the myeloma treatments. And now we have different trials that are open to all kinds of cancers. We have one, that's an immunotherapy trial that is open to most types of cancers. For patients who have had chemotherapy before, and may also have had some immunotherapy before and are still progressing. So now we have a new agent that we give immunotherapy plus a second immunotherapy agent that helps the immune system to work even better than with just one agent. So we're trying to do whatever we can to help our patients not have to be exposed to the cytotoxic chemotherapy that causes a lot of side effects, and instead use less toxic and more immune system related treatments to help treat their cancers, and it's actually working out. It's helping.
The bispecific antibody, what type of cancers does that kind of work towards? You said myeloma?
So right now we are using it for myeloma, but it is being studied in other types. We don't have them available yet for other types of cancers, but down the line, I believe we will. So at this point, it's only for multiple myeloma.
So, are you one of the only doctors providing this treatment? Someone watching just, wow, they might be asking, how can I get access to something like this?
Well, it's available on a clinical trial basis at different centers, but usually it's at the tertiary care hospitals. We are probably the only private center that has it available.
Wow, okay.
On a clinical trial basis.
Interesting. And then with something like that, how much more effective is that than today's current modern day treatments?
So right now we are using it for very advanced stage patients who have a lot of a lot of treatments in the past, and even in that setting is working very well. So my feeling is, as we move the treatment more towards earlier stage disease, it will work even better. So we'll have to wait and see how well it's going to work for the patient, but it looks like it has really great potential.
You said there's a new agent of immunotherapy that you also utilize.
Okay.
Can you tell us a little bit about that?
Yeah, the original class of immunotherapy, they are called the checkpoint inhibitors, or the PD-1 class, and those have been extremely successful. And over the last couple of years, there are newer classes of treatments that are coming out. and we are combining those with the checkpoint inhibitors to see if we can overcome the resistance to the checkpoint inhibitors. So very often we give an immunotherapy that's been approved and the patient responds, or sometimes they don't respond. Then we try to figure out, can we make them more effective by combining another immunotherapy agent that works a little differently to help overcome the resistance of the cancer to the immunotherapy. So there are multiple such agents. We happen to have a couple of them, and they work in complicated mechanisms of action that is hard to explain. But basically what they do is they take the brakes off of the immune system so that the immune system is kind of revved up, and now it starts to see the tumor cells as a foreign agent and starts to attack them better than it used to before, where the cancer cells are kind of hiding from the immune system. They have a good way of not being seen by the immune system. But if you take the brakes off the immune system, then the immune system cannot see it much easier and attack it. Yeah.
And how long within the clinical trials have you been with this particular new treatment approach?
Well, these are all very new, within the last 4 to 6 months. So we continuously are bringing new agents into our clinic to use them and see if they can help our patients. Some work very well, some unfortunately don't work so well, but when they do, it's really an awesome situation where they had no other option anywhere. There's nothing approved for them. We are able to get the new drug to them, which is really not available on the market. And lo and behold, they respond, and it's a fantastic situation.
That's amazing. I mean, with something like this, are there any other kind of clinical trials that you expect your team to be participating in soon that you really think could be opening doors in terms of therapeutic options?
So there are more agents, such as the antibody drug conjugates that I mentioned earlier. So we are getting more and more of those for different types of cancers. And also bispecific antibodies are becoming more and more available for different types of cancers.
Okay, so you see yourself potentially still using these treatments, but for expanded types, right? Understanding the type of cancer that it can treat. Is that right?
Yes, that's correct. Yeah.
Okay.
Yeah.
And maybe share with us one more story that really, maybe if you were to say throughout your whole career, this really stood out to you the most.
Sure. I have a great case of a lady with Hodgkin's lymphoma. A few years ago, she came to us for treatment, and we treated her with chemotherapy. She responded in the beginning, eventually started to grow again, and then we admitted her for more treatment in the hospital setting. Unfortunately, she was very sick. She was on oxygen. She had a tough time breathing. She was in a wheelchair. So one day she came to my office, and her father was wheeling her in, and it was a really sad scene. The father, wheeling in the daughter, who's very young at the time, and she had very bad advanced Hodgkin's lymphoma, and we were trying to figure out what to do. There were very few options. At that time, those checkpoint inhibitors, the immunotherapy was showing some results, and some good results with Hodgkin's lymphoma, some positive results. So we said, okay, let's put you on this clinical trial with the immunotherapy and see how it goes, and we have nothing to lose. So we enrolled her on the trial, and after a couple of treatments, she was off the wheelchair, off of oxygen, and that was already probably 6-7 years ago. Now she's healthy, walking around, a normal person. So she, I literally went from a wheelchair on oxygen to being in remission and just living a normal life, all because of immunotherapy.
Wow, that's
And at the time, it wasn't approved yet. So we put her on a trial, and it really saved her life. That was a great example, I think.
That's a true, wow, amazing story. So there's been, I mean, you said multiple stories where there's potentially doctors that have told patients that maybe there's no options, right? Or there's really no options for treatment. Like, what would you tell those patients if they were given such a response?
So So it's a very tough situation because when an oncologist is telling the patient there's really no option, they're often right about it. There's really either no option or no good options. At the same time, what we try to do is to go a little bit, I guess, the extra mile to look at the genetics, look at the molecular testing, look at the next generation sequencing in the tumor and in the blood, and see if there's anything we can find to figure out what we can give the patients. And once in a while we find it, and they respond and they become stabilized, or they feel better with less pain and they live longer. So basically we try to give hope as best we can. And we can't do it all the time. Sometimes we can't. And we say, look, there really is no option. Your doctor was right. But often we do find something, and we do give some hope, or we find a clinical trial for them. And sometimes they respond, and sometimes they don't. But at least we tried.
That's still, I mean, just instilling that level of hope, I feel like is huge. And what you and your team are doing, Dr. Eli, that's something that you don't traditionally see within the healthcare system. So really applaud you for that. Just what you guys are doing. You're changing lives. Not just you're changing, you're saving lives.
Exactly. We're saving lives, thankfully, and it's an amazing, I guess, feeling to be in that, to have that, I guess, the word is a privilege, but to have the privilege to be in that situation where we can actually help people and save their lives with the latest and greatest technology that we can employ for them. I mean, we like to give hope. That's always our goal. That's always our plan. Once in a while, we cannot give false hope either. We cannot tell them, oh, this is going to work, and it doesn't work. So you really have to have a good balancing act of, when you're offering hope, you also want them to know also the reality of the situation. Look, we're going to do our best, but the reality is this is a very difficult situation.
Right. I hear you on that part.
But we do want to do our best for you, so that's what we're here for. And sometimes, we succeed, sometimes we don't, unfortunately.
Aside from the clinical trials that you've mentioned right now, what direction do you see treatments going within the future in terms of general accessibility by doctors that are commonly used, or things that might come that are not even accessible yet?
Basically, I think we're going to be using less and less chemotherapy down the line, more and more of all of the immune-related treatments and the non-cytotoxic treatments and the targeted treatments. And even with radiation therapy, I hear it's going to be changing, and there are some new radiation therapy technology that's going to be coming out, where you have a PET scanner and a CT scan on the radiation machine, so it can be a lot more directed to where the radiation needs to go, and so a lot less side effects. And I just think overall, as we figure out the different pathways of the cancer cells and their metabolism or their cycling and how they divide and how they grow, and as we learn how best to target the cancer cells, instead of using one or two different, I guess, pathways, you can use 4 or 5 pathways so that they cannot keep figuring out how to survive. Then we make a real impact. We have made a lot of impact so far in the last probably decade or even less. But as we figure out more pathways, then we can really make a really nice impact in making cancer a chronic disease as opposed to a death sentence.
Wow. That's something to be very optimistic about in terms of how the approach is to go and fight cancer. Thank you, Dr. Eli. Are there any kind of finishing thoughts or anything else that you'd like to share with us that you think people should know, or anything from your perspective that you'd like people to know?
I guess one finishing thought would be that, if you are seeing a doctor and, they give you some options, but you're not so happy or it's not working, it's always best to get an opinion from somewhere else, just to get another person's frame of thought, a fresh look at the situation, and maybe some new testing, the genetic testing may offer different options. So basically not to give up, too easily.
Of
Is
course.
my advice.
That's a great finishing thought. Thank you, Dr. Eli. Really appreciate your time. Very grateful to go ahead and have you here. And I hope you have an amazing day. Thank you, Dr. Eli.
Thank you very much for your time, and it was a pleasure. And I look forward to doing more such interviews together.
Thank you. Thank you.